a little bit more. Is Mike Lighty around here? Oh boy. I'll give you a round of applause. Yeah. I think it was 2003 that I introduced my first single-payer bill, HR 676. Remember that number? Goes back a ways. And we're here to celebrate how far we've come, acknowledge what the challenges still are, and also lay out a strategy for where we're going from here. Now, you folks here, especially the nurses, you're at the heart of the subject matter. You know on a day-to-day basis, informal or formal, what's going on inside and what needs to be done. Me, I'm looking at it as a legislator that represents working people, of which there are more of us than there are of anything else, but a few of the anything else has most of the money. But money does not trump people power. And you nurses know that. And so it's with particular pleasure that I make a few comments about this important subject matter. I've got 3 issues that I've campaigned on from the beginning: jobs, justice, and peace. Now, full employment is something we're kind of moving toward. There's still lots of soft pockets. There's still a lot of work to be done. But in the most powerful, wealthiest nation in history, we ought to be able to put together an economic system that everybody that works ought to have a job, a good job, with pensions and health care and retirement considerations. And then, of course, there's the justice, political and economic justice. We're still working on the Voter Rights Act after 50 years. We're celebrating that day 50 years ago, I think it was August 6th, that Lyndon Johnson went to Independence, Missouri, to give Harry Truman the first Medicare card of all, because Truman had talked about universal health care, and it left a lasting impression upon the president then, Johnson, and he traveled with his wife to Harry Truman to let him know that he acknowledged the groundwork that he had laid in getting us to this point. Then we come into Medicaid. Now, we're talking now about people that some are living below the poverty line, but you can be in poverty living above the poverty line. So, and this is where Medicaid comes in, and we have all these discussions and negotiations about reimbursement rates and so forth. But there are countries, and we're doing a global study of this, that say that there are countries that are ahead of us in terms of providing universal health care, but they're spending less money than we are. We're always putting out extra money and so forth, but the real importance of this struggle is that we make it available to everybody that needs it. And then, of course, peace. Jobs, justice, and peace. We've got to work on that. There's so many tricky issues. I just got back day before yesterday from Africa. I was there with President Obama, and I was never more proud of him for putting Africa on the map. And he did it in a very beautiful way. And so, ladies and gentlemen, I am honored that you would spend this time with me, because my full employment bill, H.R. 1000, my health care bill, extending it to everybody, H.R. 676, and all the issues of peace in which I think the president has restrained from the pressures of conservatives to go ahead and let's give them a taste of how much military power we have. It's not how strong your military is or how many nukes you have. It's what is your diplomatic skills? How can you negotiate? And now, with the proliferation of so many military weapons, you drop some, maybe somebody else will drop something on you. I mean, this thing can start off from a little Syria and a couple of other states, and then before we know it, we're in a war. And I am proud that President Obama went to Africa to connect up with those 53 nations who are some of whom are doing their darndest to become even better and closer related to us in our struggle. And so we're honoring the 50th anniversary of Medicare. And I just want to thank Congressman Ted Lieu of California. He just joined us on the bill, and let's give him a round of applause. And before I introduce Michael Lighty, I wanted to ask Ted if he wouldn't make a few remarks before we start the panel.
Thank you, Representative Conyers, for your leadership on this issue and so many other issues in Congress. I'm honored to be a co-author of Mr. Conyers' legislation, H.R. 676, that's going to have single-payer and Medicare for all in America. We have any nurses here from California? So I'm very proud that when I was in the state legislature for nearly a decade in California, I had a 100% voting record with the California Nurses Association. I was a co-author of single-payer legislation in California every year I was in the legislature. And the reason I support single-payer has to do with the story. And when I first got elected to Assembly, I remember going to a restaurant and the waitress recognized that I was an Assembly member and she asked for my help. At the time in California, if you did not have a child under 18, you could not get government health insurance at all. And she had a daughter that had just turned 18. So this woman now had no ability to get government health insurance. She had recently been diagnosed with breast cancer. She couldn't get private health insurance. No private sector health insurance company would cover her. And it sort of became clear to me that she was going to start dying slowly because places like the free clinics in my district wouldn't see her because they don't do cancer treatment. An emergency room was not going to treat her because they don't do cancer treatment. She was going to slowly wither away, and then one day she was going to get sick enough, walk into the emergency room, they will treat her, and then she was going to die. And I thought, with a country with this many resources, this should never happen. And that's why I'm a big supporter of single payer of Medicare for all. I did support and continue to support anything we can do to enhance healthcare coverage. And we know that Medicare has worked. Before Medicare, seniors, nearly 30% were living in poverty. After Medicare, now it's less than 1 in 10. We know that before Medicare, about 50% of seniors had no health insurance at all. So this is a program that has worked, and we should expand upon it, not, as the other side wants to do, reduce it, privatize it, or eliminate it. In addition, the other thing that Medicare allows America to do is it allows us to innovate. One of the things that makes America great is our ability to be successful, to come up with amazing new products and technologies. And that only happens if people are allowed to fail. And what happens in America is you can try, you can fail, and you can try again. And we know that when you can no longer work, or if you're disabled, that we're not going to let you die. We're going to give you health coverage, we're going to give you Social Security, and this gives an immense amount of freedom for our population to do what we need to do to compete in the 21st century. So Medicare is an amazing program. My parents rely on it. There's no way I'm going to touch it. I want to expand it. And whatever I can do to help, I will. And thank you so much for having me here.
Ted, we appreciate you. I think you're number 51 on the co-sponsors list. So we're growing, and today is very important to me. Some of you remember that the person that I've respected and got me more politically active than I ever thought I'd be was Dr. Martin Luther King Jr. And the thing that he said about this subject matter, of all the forms of inequality, injustice in health care is the most shocking and inhumane. And I know you could put a lot of personal experience and comments about that. And so when I got to Congress, if it wasn't the first bill, it was one of the very first pieces of legislation. I introduced the bill that proposed the creation of Medicare and Medicaid. And I am proud to be the last serving member of Congress to have voted for both those bills in 1965. At that time, you can tell me I don't look like it, but I'm the dean of the Congress. Now, at that time, only half of the Americans of 65 years of age or older had insurance to cover hospitalization. Now, 50 years later, few can deny that Medicare has brought untold benefits to older Americans. Millions have lived longer, more productive, healthier lives because of the medical care they receive from this program. Without it, they could have incurred financial ruin, suffered needly, and died prematurely. Now, while our government made historic progress, we still have unfinished business. Despite Medicare, Medicaid, and by the way, wasn't it something on the Affordable Care Act, ACA, they voted to end it 56 times? Conservatives did. Tens of millions of Americans, despite all these 3 bills, tens of millions of Americans remain uninsured, and 7 million of which are our own children. The millions of Americans that still lack health insurance are a stark reminder of the work that we still have ahead of us to ensure that health care is available to all. And so H.R. 676, with 51 supporters in the Congress, we would extend the benefits of Medicare to all Americans regardless of health status, wealth, or age. And so would you, the nurses and the friends of ours that are here today. And because of Harry Truman's dedication to it, Lyndon Johnson went to Independence, Missouri to sign the Medicare and Medicaid bills. He wanted to honor the former president, Harry Truman, and present him with the very first Medicare card in honor of Truman's strong support for a universal national health program. And 70 years after Truman first called for a single-payer health care system, we must finally join the rest of the industrial world and make health care a fundamental right for all in the United States of America. And we're going to do that. We're going to do that. Now, Bill Moyers was supposed to be with us today, but he had an emergency and called and apologized to Cynthia Martin, my chief of staff. But thanks so much to Wendell Potter for being willing to moderate this panel. He's a former health insurance executive himself who knew firsthand some of the tactics that were used by the private health insurers to deny people who needed care. And he's the senior analyst at the Center for Public Integrity, and we're ordering his book, Deadly Spin and Obamacare, What's in It for Me. Thank you all for being here, and please, Mr. Potter, take it away. Thank you.
Congressman, thank you so much. It's really quite an honor to be here, to be in your presence. It's really one of my heroes, and I'm pinch hitting, as the Congressman said, for another hero of mine, Bill Moyers, who would like to have been here but is on kind of the disabled list today, but he's here in spirit. And he, some of you might not know this, but Bill Moyers played a pivotal role in the birth of Medicare back in the 60s. He worked for both Presidents Kennedy and Johnson, and played a key role in helping to make sure that it was passed. So let's send good wishes to Bill in New York. I'm also just honored to be in your presence. You've been at this much longer than I have, and I'm humbled to be here. I, in fact, am in many ways making amends by being here today and the other work that I'm doing. In fact, on my website under my name it says Making Amends, because much of what I'm doing these days is really to try to make up for the work that I did for many years inside the insurance industry, and to acknowledge that for many years I was doing work that was perpetuating a system that was very, very profitable for some of my former colleagues and shareholders, but a system that was very broken for growing millions of Americans. When I finally woke up to the work that I was doing, I ultimately decided to go public. I was persuaded to do that, and my first time out was before Congress on the other side of the Capitol. But I was grateful and fortunate to be invited to testify before several committees here on the House side during the healthcare reform debate. Another hero of mine wanted to be here. He is here by video. We're going to see a video of Dr. Don Berwick, who, as many of you all know, has been advocating for a better healthcare system in this country for many, many years. He served under the Obama administration for many months as the head of the Centers for Medicare and Medicaid Services. Interestingly, as you probably know, he was never confirmed by the Senate because of a sin that he committed at some point in his past. He acknowledged that he admired the National Health Service in the United Kingdom, and there were many folks on the other side of the hill who just thought that was unconscionable, and so President Obama appointed him during a recess. Thank goodness. So why don't we tee up the video of Dr. Berwick.
Hi, I'm Don Berwick. I'm President Emeritus and Senior Fellow at the Institute for Healthcare Improvement here in Cambridge, Massachusetts. I'm also former administrator of the Centers for Medicare and Medicaid Services, and I'm delighted to help celebrate the 50th anniversary of Medicare and Medicaid. As administrator, I got to see the enormous power and potential of leadership for the benefit of the public in the arena of healthcare. Every day that I went to work, I got to think about the well-being of 100 million Americans in Medicare and Medicaid, people who, because those programs exist, have coverage they otherwise would not have. I also got to fight for their rights and their benefits. I got to fight for the quality of their care. We had transparency so that I knew how the care was going, and I could spot areas where we really needed to invest further using the tools of public policy to help make things better for patients and families. It's the best job in American healthcare. I think this country should celebrate the enormous, majestic step it took in the setting up of Medicare and Medicaid, and frankly celebrate also the progress of the Affordable Care Act. As controversial as it is, think about it. If that act is successfully implemented, 30 million more people will have benefits from the benefit of coverage from healthcare, so they won't have to wake up in the middle of the night worried about going into bankruptcy. They'll also have a government at their side fighting for better and better care. Where now? Look, I think there are two premises. Premise one is healthcare is a human right. Every Western democracy has made that declaration. Ours should also. Americans should have access to care, period, as a human right. The advances that were made in Medicare and Medicaid can be brought to the benefit of everyone in this nation if we would commit to that fundamental principle, Medicare for all. And the second principle is that healthcare can and should be much better than it is. We know from the guidance of our National Academy of Sciences that better care is possible, feasible, and not yet in our hands. Care that's safe, effective, patient-centered, timely, efficient, equitable. Care that meets the demands of the triple aim, the social need for healthcare, better care, better health, and lower cost. Medicare and Medicaid can lead, have led, in pursuit of that triple aim, in pursuit of that better care. I got to work on that as administrator, and we can bring those benefits to all Americans if we commit to the kind of healthcare system we want and need. The way there is not through exhortation or demands, it's through redesign, constant redesign, using the imagination of America to reinvent the care system that really will meet our needs, where we need care, when we need the care, how we need the care. We can do that. The leadership of Medicare and Medicaid in pursuit of better care and universal care for everyone has been unparalleled in this nation. We need to bring those benefits, universality, healthcare as a human right, and continual improvement of quality to absolutely everyone. That's the pursuit I've been engaged in my career and will continue, as I know you will.
And Dr. Berwick certainly is continuing his work. He's a real treasure. We have other treasures on the panel today. We're going to have a good panel discussion. I'm also honored to be among the panelists who are here today. I might acknowledge one thing that before we introduce the panelists and we begin the discussion. When I began, after my testimony here, I began speaking around the country. And I've done that quite a bit. But during the debate on what became the Affordable Care Act, everywhere I would go, invariably people would come up to me and say that they were just 2 years away from being eligible for Medicare, or 1 year, or 6 months. In many cases, they didn't have coverage at all because they couldn't get it because of the practices of the insurance industry, or they were in plans that were just becoming unaffordable. So they were really looking forward to being eligible for a program that, thank goodness, has been around now for 50 years. My mother from Tennessee would say maybe those folks were wishing their lives away, but I fully understood what they were saying. I'm 352 days away from Medicare, so I'm among them. First on our panel is the president of a wonderful organization that I have become very fond of, very much aware of the work that they've done over 2 decades. Robert Zarr, Dr. Robert Zarr, is a board-certified pediatrician at Unity Healthcare in Washington, D.C., where he cares for low-income and immigrant populations. He's president of the Physicians for a National Health Program, which advocates for universal, comprehensive, single-payer national health program. PNHP has more than 19,000 members and several chapters across the United States. And I was fortunate to be invited to speak at a chapter meeting and a fundraiser in Los Angeles just this last weekend, and had the privilege of meeting Congressman Lieu there for the first time. I'm going to ask each panelist to speak for a few minutes. I'll introduce each one of them separately. And then after their opening remarks, we'll have a discussion. Dr. Zarr?
Thanks so much for that kind introduction. Thank you for inviting me here today to speak. It is always a pleasure and an honor to be among such giants in social justice. First, let me tell you a bit about myself. For the last 14 years, I've practiced primary care at a community health center right here in Washington, D.C. I love what I do, but not necessarily how I have to do it. I cherish the relationships I've built with thousands of patients and their families over many years. I enjoy listening to their concerns and offering advice. I'm grateful for having an employer who allows me to practice alongside colleagues who share my commitment to provide high-quality, comprehensive care to all, regardless of their ability to pay, their employment status, or their language and culture. That said, there's still lots of room for improvement. I'm expected to see 22 patients a day, regardless of their complexity of their medical condition or their often challenging circumstances at home. I am disheartened when my 15-year-old obese patient is asked to spend $800 so she can be seen at the concussion specialty clinic to help her recover from a lacrosse head injury. I am saddened when my uninsured 17-year-old patient is refused a post-operative follow-up visit with his surgeon. I am frustrated when patient after patient deserves more, but gets less. Not because I'm not working hard, but because of the irrationality and cruelty of the complicated way in which we pay for health care. Having grown up and trained in Texas, I have my Texas pin here, I was taught to embrace words like self-determination and freedom, even if the real world doesn't always measure up to those ideals. But something sunk in, and now I find myself wanting to be free to practice medicine without the bureaucratic shackles imposed on all of us by the profit-seeking private insurance companies. The primary mission of private insurance is to create profit for their shareholders, not to provide care. They maximize their profits by enrolling the healthy, avoiding the sick, denying claims, increasing premiums, and erecting barriers to care like copays, bureaucratic thickets, and narrow networks. The Affordable Care Act hasn't changed this picture very much. These practices are good for neither patients nor physicians. Patients suffer needlessly, and doctors like myself are afflicted by endless bureaucratic paperwork contributing to burnout. My home state happens to be the birthplace of Lyndon B. Johnson, who signed Medicare into law 50 years ago. Medicare has since become one of our nation's most beloved social programs. And traditional Medicare, in contrast to the Advantage plans, offers important lessons. It runs on very low overhead, around 2%, versus the 12 to 15% overhead typical of the big private insurers. It allows seniors to go to the doctor and hospital of their choice. It controls cost better than private insurers do. And though it serves the oldest and sickest segments of our population, it only makes perfect sense that all my patients were covered by a single, simple program like Medicare. The administrative savings would be immense, an estimated $400 billion a year. That's more than enough money to cover everyone's medically necessary care with no copays or deductibles. In fact, in 1965, the authors of Medicare intended to create a social insurance fund to cover all Americans, not just seniors. We still need such a single-payer program. We have to go beyond ACA. Too many people are still suffering and dying prematurely. As a patient, imagine never again having to worry about whether the doctor's office, hospital, or pharmacy takes your insurance, because there is only one insurance: improved and expanded Medicare for all, which pays all the bills. As a provider of health care, imagine never again having to worry about being paid for the services you provide. Imagine working for yourself and having the freedom to set your hours, most conducive to your lifestyle and to that of your patients. Imagine the autonomy of running your own practice, or at the very least, spending less time on paperwork hassles. This is no pipe dream. Medicare points the way. We merely need the political will to enact legislation like H.R. 676, the Improved and Expanded Medicare for All Act, into law. When it comes to Medicare, the three crucial ingredients are right behind you: protect it, improve it, and expand it. Let's celebrate Medicare's birthday by extending it to all. Thank you.
Thank you, Dr. Zarr. And not only is Dr. Zarr wearing a pin from Texas, he's wearing, hands down, the best tie in the room. If you look closely, you'll see their presents, birthday presents on the tie. So he really is celebrating a birthday today, the 50th anniversary, 50th birthday for Medicare. Next, we'll hear from Andrea Miller. Andrea is the co-executive director and the IT director of People Demanding Action, which is the activist arm of Progressive Democrats of America. People Demanding Action helps foment and evolve grassroots movements to rebuild American democracy, freedom, peace, and justice. As a grassroots political action committee, the Progressive Democrats of America operates both inside the Democratic Party and outside in a movement for peace and justice. Andrea, thank you, and let's welcome Andrea Miller.
Thank you. Thank you all very much. What I'm going to talk about today is, I remember a very dear friend of mine, an activist from Petersburg, Virginia. Her name was Joanne Evans Davis, and Medicare for All was one of her biggest issues. I met Joanne back in 2006 out on a picket line in Virginia, and when you meet somebody on a picket line, you definitely are going to become fast friends with that person. Over the years, Joanne and I worked on a number of issues, and Medicare for All was her absolute favorite. In 2009, we did town halls, and Joanne was always the volunteer at the desk, signing everybody in. And in 2010, we thought, she's ready to start and take over a chapter right here in Petersburg, Virginia. And on that first organizing call that we had, I noticed that Joanne had a cough. And she had to keep muting herself because the cough wouldn't go away. And so I drove down the next day to see Joanne, and I said, Joanne, I don't think that's a cold. It doesn't sound like a cold. You need to go to the doctor and see what that is. Joanne worked for the city of Petersburg. She'd worked for the city for years. And she said, I've been meaning to go to the doctor, but I don't really have the money for the copay. I can't go. I said, Joanne, how long have you had this cough? She said, off and on for about 4 months. So I drove her to the doctor, and I paid the copay. Joanne was diagnosed with stage 2 cancer. The cancer spread from her lungs on the back of her heart. It was inoperable. And it was Joanne's dream to be able to come to Congress and tell in Congress and Representative Conyers how important Medicare for all was for people like Joanne, who are among the working poor, who worked 40 hours a week, earning less than $21,000 a year. And she had done this for years. So I know that Joanne today would be very delighted to say, even though she did not see that birthday, happy 50th birthday, Medicare.
Thank you so much, Andrea. Next, we have Michael Lighty, who is currently the Director of Public Policy for the California Nurses Association, National Nurses United, where he coordinates the national political and legislative work for the 150,000-member Union of Registered Nurses, many of you here today. As you all know, the organization, some of the main issues include healthcare reform, patient rights, labor law reform, and budget, tax, and economic development policy. Michael has spoken and organized throughout the country for more than 20 years on healthcare reform, financing, and delivery issues. I've known of Michael for quite a long time. In fact, I think even before I left Cigna, when I was trying to decide whether to do that and what to do next, someone introduced me to Michael, and he was one of the very first people I talked to about what I hoped I might be able to do for the next chapter of my life. So, Michael, thank you very much, and thank you for all you do.
Thank you, Wendell. Really appreciate it. And it's actually an extraordinary honor for me to represent the nurses here and around the country in this work that we do. It's really all of the nurses that animate this work and inspire me, and I know many, many others, to ensure that nurses are able to do what you were educated to do in terms of patient care and how much the present system pushes against that. And it's a special honor as well to have John Conyers give that shout out to me. Is that is a beautiful and deeply honorific experience, Congressman Conyers. And all I'd say is if you were the dean at my college, I think it would have been a much better experience. So Congress is lucky to have you as the dean. That's all I'll say. I think, Wendell, your really kind of personal transformation is indicative of really what the health system has to go for, because, of course, a lot of Americans grow up with the belief that, well, you know, it's a free enterprise system, you know, the private sector is efficient, can do things better, and, of course, nothing wrong with making a dollar. And so that really, in a lot of ways, is the American way. And then you start looking at Joanne's story and the human experience in our healthcare system, the experience of doctors and nurses, and all of a sudden you realize, you know, there's something wrong with how America organizes the healthcare system. And private insurance is at the root of that wrong. And so when we look at that kind of from a policy perspective, if we believe that health is something that is a risk that we take by living, like when we drive a car, that involves risk, then you say insurance is the appropriate way to deal with that, to deal with health. It's a risk, so I need to insure myself against the risk that I will get sick. If, on the other hand, you believe that health is a right, that we have an inherent right to good health, and that that's what a civilized society should provide, then you look at it very differently. And it's not a matter of insurance. It's a matter of being guaranteed the health care you need to maintain wellness and health. And that shift in that paradigm, I think, should drive how we look at the healthcare system. Because the reality is that the assumptions we make about private sector efficiency, the assumptions that we make about what drives healthcare costs are the opposite of what conventional wisdom tells us it is. So, for example, we have this very handy Medicare 50th bookmark for you to take home with you today. And on the back is a comparison, actually a relatively modest comparison on administrative costs. 1.6% for Medicare, 1.6% for Medicare, 18% for private insurance. So the public sector is vastly more efficient when it comes to paying for healthcare services than is the private health insurance system. I often get to talk about my important health and benefits information I get from Aetna. Right? I imagine Cigna used to send these out. Everyone ever get one of these in the card? I have employer insurance, right? So it's all the fine print that the lawyers make them. Not that I'm looking at you. Yeah, I don't. Yeah. No. That's the other end of the table. That's right. So it's what the lawyers make them say. And my favorite part is actually the last sentence. Aetna does not provide care or guarantee access to health services. Well, then what the hell are they doing? I mean, I don't know. I asked the business guys, do you routinely pay 20% to something that adds no value to your business? Is that the American way? I don't think so. And so when you start unwrapping these assumptions that we make about healthcare, it leads to the conclusion that there is a better way. And of course, it turns out that most countries enact some version of national health insurance as a publicly financed benefit. And in most cases, it is privately delivered. It is. We should be clear, we're not talking about socialized medicine. We're talking about public financing of healthcare and mostly private delivery. And in the reality is 60% roughly of healthcare spending now is public tax dollars at the federal, state, and local level. So it's not like we're not already doing public financing. We're just doing it through the most inefficient system that we could design. And I think that the reality of that inefficiency is in our present experience with the Affordable Care Act. We're going to spend a lot of tax dollars doing some very good things through the Affordable Care Act. But at the end of the day, we're also going to leave about 30 million people uninsured. So we're not going to achieve universality. And when the authors of the Affordable Care Act looked at health policy, they designed it with a primary assumption in mind. Remember this, that the reason that American healthcare is so expensive is because Americans use too much. That there's overutilization in the system, there's waste in the system, and that if Americans were to spend more of their own money in the healthcare system, skin in the game as it were, then you could reduce costs. And this was Peter Orszag when he was head of OMB and engaged in the Affordable Care Act development. Others in the administration really took this as their primary principle, that overutilization and waste needed to be wrung out of the system, and we could then have long-term cost control. And I know members of Congress and staff often deal with that assumption as well. And that's the basis for what we've heard is the excise tax that is going to go into effect for what are called Cadillac health plans. Those Cadillac health plans are also known as good union health plans. Good benefit plans. And the idea is, hey, if we tax good benefit plans, then you will actually develop plans that don't over-provide benefits. And a group of presidents of international unions met with the president and his health policy advisors and said, hey, those excise tax are going to kill our health plans. It's just going to make the 40% tax is going to fall on the workers. The workers aren't going to be able to pay it. They're going to reduce benefits, and good plans are going to go bad. And the response from the administration was, hey, you really have better plans than you need. Because their assumption is over-rich benefits produce higher costs and waste. Now, the reality is very different. You compare, for example, Americans how many times Americans go to the doctor on average in a year? Dr. Bill, 4 times. In Japan, 13. Japan pays about half as much per capita as the United States does on health care. So if people in the U.S. are using too much health care, but in Japan they're using 3 times as much in terms of doctor visits, maybe that's a false assumption. Similarly, you look at the most highly industrialized countries in the world, compare hospital length of stay. You'll find the U.S. at the shortest length of stay end of that comparison, and countries that spend half or even less than half of what the U.S. spends per capita have longer stays in hospitals. But we're told that we got to get people out of hospitals, we got to make them pay when they go to the doctor, we got to make them pay when they buy insurance, we got to make them pay when they buy drugs, because otherwise Americans are going to bankrupt us by using too much health care. The reality is, why does health care cost so much? Because the prices are high. Why are the prices high? Because they can get it. Because they can get it. Californians pay a lot for gas to put in their cars. Why is that? Because they need it to get around, and the oil companies can get it. And the same with healthcare. The more drugs cost, the more, Wendell and I have talked about this, the better revenue for the insurance companies. That justifies their premiums, and their profit margin on those higher premiums goes up, even if prescription drugs costs go up. Hospitals will actually negotiate deals with insurers off their list price, as it were. But those higher costs for hospitals also translate into higher premiums, which also generate a higher profit margin for insurers. So the whole problem with healthcare actually is that there is an incentive toward revenue in each sector of the system that then drives costs up because prices go up. So of course, in a system that is publicly financed, all that goes away. All the problems in the healthcare system as it's organized around maximizing revenue for each participant, drug company, hospital, so forth, is changed. You eliminate the private insurers, and then you're able to pay not for their profit margin in hospitals and services, but for the actual cost of patient care. That's the difference. So when we talk about Medicare for all and single payer, what nurses talk about is a single standard of safe therapeutic care. And in a system where you pay for patient care instead of the revenue generating model of the current one, then you can pay for patient care. And when you pay for patient care, your focus is on access, on need, on prevention. That's what comes to the fore when you pay for patient care. And the difference is that in a system where patient care comes first, the clinical judgment of doctors determines what the patient gets, not the ability to pay. What we have in the current system is services based on ability to pay. The more you can pay, the better the system. And there's very good analysis recently that, in fact, the healthcare system in the U.S. is uniquely designed to benefit those with the most money. Because the high-tech interventions, the huge medical centers, the best in the world medicine are really reflective of what the most well-resourced people in this country can pay for. So there's an issue of distributive justice, injustice, and justice at the heart of this debate. I want to finish with 2 points. One is, who saw the New York Times story today about Medicare and Medicaid? We are at a very, very defining moment for these programs that it is an honor to be with someone who voted for them. That is extraordinary. The private health insurance is taking over Medicare and Medicaid. And that revenue model, that revenue enhancement model is going to and is continuing to and increasingly invade the public financing model of these essential social programs. And what will be the result? Rationing based on ability to pay, access based on ability to pay, enhanced revenue for the 1%, and less access for the rest of us. So that model is coming increasingly to define Medicare and Medicaid. What we hear, though, is that we can't change it. We have to accept this. And I have a message from the Executive Council of the AFL-CIO, which is meeting as we speak in Silver Spring. And they did something historic yesterday. They adopted Medicare for All as an essential part of their Raising Wages political program for this country for 2016. Yeah. Because these are the leaders of the American labor movement, and they realize something fundamental. And that is, this system is destroying employer-based insurance. This system is going to eliminate, Jim, those union health plans that have defined, in many cases, the gold standard. There are going to be the excise tax and all the other pressures of this system are going to eliminate that. And what are we going to be left with? We're going to be left with two alternatives. One, I get a check, a voucher, what have you, and I go out there and try to find an individual insurance plan that maybe includes my doctor, and maybe I can afford it if I get really sick, but is most likely to bankrupt me. So you're on your own. Or you can go for Medicare for All. Those are the choices we face. And I believe, with all my heart, that the red scrubs and the white coats are going to transform this healthcare system with the rest of us. Because you all have the credibility, the expertise, and the moral authority to get this country to live up to its highest ideals of justice and equality when it comes to the most basic right of health for all. Thank you.
Michael, thanks very much. And Michael he's really telling the truth, particularly about the high deductible plans that insurance companies are forcing more and more of us into. One of the times when I testified before a House committee, I said that if Congress acquiesced to the demands of the health insurance industry, like locking in high deductible plans and implementing things like the Cadillac tax, and if they didn't include a public option, they might as well call what they passed the Health Insurance Industry Profit Protection and Enhancement Act. And the bill was signed into law in March of 2010. In that space of time, the two companies I used to work for, Humana and Cigna, have seen their share price increase 400%. It has been an incredible vehicle to enhance the insurance industry's profits. This is a great day for me because I have heroes of mine all around me, including our next speaker. Robert Weissman is a public interest advocate and activist, as well as an expert on a wide variety of issues ranging from corporate accountability, something near and dear to my heart, and government transparency, to trade and globalization, and economic and regulatory policy. He has been leading Public Citizens since 2009. He has spearheaded the effort to loosen the chokehold of corporations, and the chokehold that the corporations and wealthy have over our democracy. He also has expanded Public Citizens' work to include a single-payer Medicare for all healthcare system, for which I know we're all very grateful. So let's please welcome Rob Weissman.
In the spirit of the room, I'm going to violate the rules of the panel and come up here. I don't know if is this working? I'll just do it without it. Because I want to be able to see you and subject you to seeing me. It's very good to be in a room of so many red shirts. Thank you so much for all for being here. Do you remember when the Affordable Care Act was being debated and there was all the talk about rationing and the crocodile tears that were being shed about the prospect of the rationing we would have if the Affordable Care Act were adopted or some version of it? Well, of course, we had rationing at the time, and we have way worse rationing now. And those tears aren't being shed anymore, at least those same people aren't crying about the rationing that exists in the system. So they never meant it along the way. But they were right that the idea of rationing health care is a moral offense and an outrage in the richest country in the world. So we do have rationing right now, and we should be outraged about it. They should be outraged about it, but we have to be outraged about it. If we were in a poor country, it might be a choice. We might say we're resource constrained, we got to do the best we can do, but we're not in a super poor country. We're in the richest country in the world, and we have a better way available to us. So how is care being rationed right now? We've heard both anecdotes and some of the data and the analysis about it, but just to sort of review this, because I think in a lot of ways it's the defining feature of the system we live in right now. So even with the expansion of coverage under the Affordable Care Act, we still have about 13% of the population who don't have insurance. As Michael said, when it all shakes out, it's still going to be 30 million people who are uncovered. So we know what it means not to have insurance. If you don't have insurance, you don't go to the doctor, you don't go to the clinic, you don't get the care you need. Tens of thousands of people die as a result every single year. Hundreds of thousands suffer, maybe many more, needlessly. That's one form of the rationing that goes on. But here's rationing if you have insurance too. Right? They tell you can't get the care you need. The insurers tell you can't get the coverage, get the treatment the doctor says you need. But even more profoundly, as I think Michael was saying, all the co-pays, all of the deductibles, all of the overlays of the cost-sharing schemes, those keep people from getting care by design. That's the intent of it. And you know what? It works. It works big. A quarter of the population says they don't go to the doctor at least one time a year for some condition that they think needs treatment because of financial reasons. More than a third of the population says that there's some access problem they face every year as a result of cost. Almost 1 in 5 Americans don't fill a prescription because it costs too much. They have coverage, but some way or another, they're paying for it, and they can't afford it. So we have rationing right now. We have rationing because the system is so stupid, right? Partly it's just evil and profit, but it's also stupid. We do dumb things. Now, we do dumb things because they're designed too. They're designed by the powerful interests. So even in the best system we have, Medicare, as we see, being eroded and privatized and eviscerated, right? Medicare Part D can't negotiate for drug prices, right? We run the system through private insurers, and we prohibit the system from negotiating for drug prices. So we just did a study. Medicare pays 198% of the median price that other rich countries pay for brand name drugs. Not because it costs so much to make them, not because of some imaginary expense required for R&D, just because, as you said, because the price is so high, and we could do something about it, and we choose not to, and we legislated that Medicare can't do anything about it. So we have rationing. That's why do 1 in 5 people not pay? Because it costs too much. They don't have coverage, and it costs too much. We have new life-saving drugs. Most drugs, turns out aren't that good. Most new drugs really aren't that good. They don't do that much. But sometimes they really do. We have new life-saving drugs that are coming on the market now for hepatitis C. There's at least 3 million people, maybe more like 5 million people, right? You're nodding, right? In the country who have hepatitis C. It's still early days, but it seems like all of them should probably get these drug treatments and probably get it right away. Well, the companies Gilead and AbbVie and Merck, when they come on the market, want to charge the sticker price is $84,000 for a 7-week course of treatment. $1,000 literally, $1,000 a pill. that $84,000 or $94,000 for the combination therapies that are better. You know what it costs to make that, to actually make it? $200. Not $200 a pill for the $1,000 pill, $200 for the $84,000 worth of pills. So we can choose to live in that system. We can give them monopolies and say, yeah, you have a monopoly and you get to hijack us. Or we could say, no, like, we're going to at least negotiate with you over the price. You don't just get to tell us. We don't want to give you $300 or $500 billion in profit to keep people alive. That's what that works out to be. Or we could say, we're not going to give you monopolies, or you don't get to have monopolies that give you the right to charge whatever we want. We can do those things if we choose to, but we choose not to. Instead, we choose to have rationing. And so we choose to have people die. We choose to have people be sick for no reason. If we had single-payer Medicare for all, expanded and improved Medicare for all, as the bill is now called, we would do away with all this stupid stuff. We'd do away with all the stupid stuff which is there by design, and we would do what we should do as a matter of right. You just fix all these problems, and not just these. We do more in preventative care. We make sure that treatment was rational. We would do all sort of the right stuff. But we're a ways away from that. And we are at a point, I brought this up because like 6 minutes before the panel started, I got an email from my friends at the Chamber of Commerce also celebrating the anniversary of Medicare. But the subject line, I forget the subject, we sent out an anniversary message today too, I forget what the subject line was. But I think thousands will die actually. Thousands will die if we don't fix and expand Medicare. The subject line from the Chamber of Commerce is ticking time bomb. And the ask is, please sign the petition to help destroy Medicare. So we face some big challenges. But the good news is, I'm just listening to you talk about remembering 50 years ago and 50% of older Americans not having insurance. And it is such a great story. Really do have to celebrate and get these cupcakes distributed if you haven't already. But the thing that's so amazing about that story is we didn't just sort of make it a little bit better. We didn't go from 50% to 30%. We didn't even go to 10%. We just said, we're going to do it for everybody, right? You're 65, you get medical coverage, deal is done. So that has to inspire us because it's a great achievement historically, and it's an inspiration of what we know we can do. It's going to take a lot of hard work. I know a lot of you were out sweating this morning, so thank you for doing that. I know you're all sweating walking the long hallways here doing the lobbying. We're at 51, you say. We got to get up a little bit higher than 51 to win this thing, but that's what we're going to do, all working together. Thank you all for everything you are doing.
Thank you all very much. I think we have a little bit of time for some Q&A, don't we? Yeah. One of the things I would encourage you all to do, by the way, is actually read H.R. 676. It would get rid of a lot of the stupid stuff that Rob was just talking about, and it really is a common sense approach. To use some of the words I used to use in the industry, words are important to use. It's a real common sense approach to fixing our healthcare system and getting us to an improved Medicare for all system. Dr. Zarr, you mentioned, or you alluded to the fact that when Medicare was created, those who were hoping that it would become law and become the important program it is, thought and hoped that it would be a much bigger program, that all of us would eventually be in a Medicare program. What happened? Folks, what happened over the course of the last 50 years? Why are we still fighting for Medicare for all?
You brought it up.
You were.
I wasn't born yet, so I can give a go at it. My interpretation, given what I do, given my age, given the era that I've grown up, and given what I've been trying to accomplish every day when I go to practice medicine, is that what I see happening and what I see have happened over the last 50 years is, frankly, this, gradual and sometimes very quick corporatization and privatization basically dismantling what we see in front of us. So I think, as you pointed out, Michael, that even with Medicare and Medicaid, two really important institutions. I mean, even as they stand today, they're still very important. In fact, so important that nearly 100% of my patients are either eligible or enrolled in Medicaid, where I work. So can you imagine what would happen if Medicaid disappeared tomorrow? Well, I wouldn't have a place to work, right? So, I mean, there is still a very substantial societal value that we all place on the current institutions. But as you pointed out, they've been incredibly privatized. And over a short span of 14 years, that's not very long, 14 years that I've been working with this population of children who depend on Medicaid, I have seen so much privatization and so much cost shifting that my patients cannot afford the medicines. And what I mean by that is that D.C. Medicaid is actually pretty good, pretty progressive compared to maybe Texas Medicaid. And I'm from Texas, so I trained there, grew up there. But what I mean by that is that there is this constant re-enrollment and disenrollment. And, when someone's sick, it's not as if, they should have to ask this question, am I currently enrolled, and does my card cover that? And that's precisely what has been happening over the last several decades, is that it's stupid, but it's planned that way to make it very complicated for us to receive appropriate care and to provide appropriate care. So maybe someone else on the panel can, maybe go in more detail as to the sort of historical perspective of what happened.
Well, I think Robert, that just very quickly, it's not a coincidence that we had a high water mark in '65 when we passed Medicaid and Medicare and the Voting Rights Act, and that since then the movement for economic and social justice has been overtaken by a movement from the right to against government, and has identified government, as Ronald Reagan said, as the problem. And so you're in a political dynamic that has shifted from government can do good in the aftermath of Vietnam and Watergate and the Reagan Revolution to government must be scaled back. And that has a huge, I think, is a huge factor. I think the other factor is that, quite frankly, the right wing is targeting these very programs because they're popular. Because they know if these programs go along with Social Security, there is literally no other reason why Americans are really going to like their government. And the expansion of corporate power, the expansion of private interests, and the donor class in elections, all those, I think, are factors. Now, you moved from a system where doctors were the initial opponents, right, of, quote, socialized medicine, to a situation where private practice is virtually non-existent because it's been assaulted by the corporate healthcare industry. So doctors now have changed their position, but in the meantime, major institutional players. All of the congressional folks here know that the healthcare industry, not Wall Street, but the healthcare industry has the largest lobbying force here walking the halls of Congress. I think that may have something to do with it.
Let's skip a few years from '65 to 2015. The current system we have now, the Medicare system, still has shortcomings, and we are at a point of needing to look to see how we can improve the current Medicare program, how we can save it from further privatization. Let's take a look at where we are now and what we need to do in the future and how we're going to get there. We do need to improve it. How can we put traditional Medicare on a same competitive plane with the Medicare Advantage plans that are being overpaid, and because they're overpaid, they are attractive to a lot of people. What do we do?
Well, the Affordable Care Act really tried to eliminate the subsidies that the Medicare Advantage plans got, right? And when we talk about Medicare Advantage, we're talking about private HMOs that put seniors into networks. And rather than being able to go take your traditional Medicare to any doctor you want, you have to go to those network of providers. And they also the advantage of these is that it reduces the copays or eliminates the copays for seniors when they go to those doctors, or also use the pharmacy benefits. So what we have to do, honestly, is we have to completely eliminate that subsidy to Medicare Advantage. And that's a huge cost savings for the healthcare system, because initially Medicare Advantage was about 14% more expensive than traditional Medicare. That's gone down somewhat because of the Affordable Care Act reforms. So we have to reverse that privatization trend by ending that subsidy for Medicare. The problem you've got with Medicaid is that the HMOs in Medicaid are so attractive, particularly at the county level where actually Medicaid is fully implemented via the states, is that that's the only way that the states and the counties have been able to save money, is to put them in these narrow network Medicaid HMOs, because many providers don't take Medicaid because the reimbursement is so low. So the only way I think there, in the case of Medicaid, is to fully fund the benefits so the reimbursements go up. If you had higher reimbursements, you wouldn't need HMOs of networks to get doctors to take Medicaid. They would just take it because they're adequately reimbursed. Medicare basically pays for hospital and doctor costs, not their profits, excess revenue, but their costs. Medicaid generally does not. And so that is a real disincentive to take it. So and then the other thing is what Rob was, negotiating prescription drug prices, right? Bulk purchasing of prescription drugs. Medicaid has some ability to pay the lowest cost drugs, but lowest price for drugs, Medicare does not. And if we were to give those two programs the authority that the Veterans Administration has to bulk purchase, right, then you would lower those prescription drug costs. Those things would dramatically change the cost structure of those programs before we can implement it universally.
Rob?
Maybe just tying this question and the previous one together, I think there's sort of the economics of it, but there's also a political element. And so the answer on Medicare Advantage is that we have to just Medicare has to be a single-payer program again. And not just because that's right and it's more efficient in the ways you're describing, but also because as long as you have these guys in the game, you can't beat them on making the rules. They will make the rules better because we can't keep up with them. There's too many of them. And they have too much influence, and they can put a little provision in here, negotiate a little deal there, and they'll never stop. As long as they've got a role, they will never stop. So I think they have to be eliminated first from Medicare, and then they've got to be eliminated from the healthcare industry altogether. That's the story for why we couldn't take the next step. It's because there's just too much power. You didn't get them out of the way. They're going to keep fighting. Instead of just sort of maintaining the status quo, their position was let's intrude onto the sort of partial single-payer program you've put forward. So I think there's this big political piece too, and we just sort of got to, all these little incremental things we have to do, we just got to step up and just say there's no role for them, and it's not, and it's not like that. There's nothing radical about saying that. It's not just like a ideologically anti-corporate point of view, which is fine, but and I share, but because they're anti-efficient, it's an easy case to make.
We should just point out, Wendell, that folks are leaving to go to their lobby visits. That's why they're not being rude. They want to get more sponsors for HR 676.
If I just may point out, on your way to your lobby visits, point out that the Medicare Advantage plans run at an overhead of an average of 14%. And as Michael pointed out, traditional Medicare runs on an overhead of 1.6%, right? So, I think the word you used is spot on. Eliminate. Right. Really, and it's important because we need to eliminate the private delivery or the privatization of Medicaid and the privatization of Medicare. They need not exist. They actually create so much enormous waste. When I mention that $400 billion a year in administrative overhead, that's part of that. These Medicare Advantage plans are part of that waste. The Medicaid HMOs are part of that waste. There is no need for them. And in fact, there's a couple of states that are examples of taking Medicaid that had been privatized and reversing the clock, going back in time, and actually having only straight Medicaid. I think Oklahoma is one, believe it or not, and the other, I think, is Connecticut. Don't quote me on that. Here I am on a panel saying don't quote me on that. But there are 2 states, and interestingly enough, they actually measured health outcomes and access and quality measures, and they didn't go down. And guess what? They saved money. Common sense.
Wow. On that note, being mindful of the time and the work that still needs to be done, and I understand, am I correct that they're cupcakes? Oh, they're all gone. I thought I was keeping you away from cupcakes, but no, that's not the truth.
How are the cupcakes?
All right, folks. Thank you so much for coming. Happy birthday, Medicare.
Andrea, I was at the park earlier, so I heard you speak at the